I haven't come very far. In fact, I could actually have walked here, but wasn't quite so efficient on leaving. I just want to start just by reflecting on Julia's really interesting talk, and just to say that this is something that we, certainly we as oncologists, I think really very actively think about. So it's not something that's accidental in terms of the way we do consultations. I don't know that we always get it right, but it's very purposive, the way we try and manage communication and listening, and I think really trying to empower people in terms of the way we operate and run our consultations. And it's always quite humbling to appreciate how the kind of strengths that people offer in that setting, it's actually quite remarkable. So I've learned more from all the people that I've seen over the years than anybody has gained from me. Anyway, so I just want to move on to talk about why I'm here. So I'm going to talk about managing the adverse events from immune therapy. And this is a cartoon that kind of represents how I talk about therapy. And it just is quickly to revise what we all know and have been discussed in the rest of this conference about how the treatments that we have available for melanoma. And very briefly, we know that there's these molecularly targeted therapies. The point I want to make here is that these directly act on the cancer cell. And that is quite different from this robot wars type machine here, which represents immune therapy. And the point is that it acts indirectly. So when we use the drugs, the immunotherapy drugs, they do not attack the cancer cell. They act on the immune system, and it is the immune system that attacks the cancer cell. And the point about this diagram is this back bit here. So the analogy I often use is about the immune system as a machine, and that the drugs we have are not identical. So drugs like ipilimumab act as the ignition key so that they serve to activate the immune system if the immune system was not already able to recognize the cancer cells. So they turn on the immune motor. And here we have these other drugs, nivolumab, pembrolizumab, and the other ones that are coming through of that class. And these act as the agent that releases the brake, so that assuming the motor is already running, then these drugs release the brakes and allow the immune system to attack the cancer. And then I want to just reflect in the next two slides about what we're trying to achieve with treatments. And this again reflects or is about efficacy, not about side effects. But we just need to remember that our aims here are to control symptoms. So we want rapid relief of the burden of cancer and that people to feel better from the cancer. We want to lengthen life. Now, lengthen life in cancer, I used to treat other forms of cancer as well, has often been lengthening life by a number of months. Now, that's a useful and important achievement for many people, but it's different to the next thing, which is changing the number of people who are long-lived survivors. So not just increasing length of life by a number of months, by increasing the proportion of people who are living for years, if not decades. And that's a really important goal. And then also to act in an adjuvant way. So where people have had things removed is to increase the chances that they're cured. So those are our goals. How do those map onto side effects? Well, on the right-hand side there, what we're trying to do is to lengthen life by months. It really is crucial that the treatments are manageable, that their toxicity is limited, that they're tolerable, and that and they also achieve rapid relief of symptoms from the cancer. On the right-hand side, no, I've got it. That's right, the right-hand side. Hit this side, yes. Is what is about length of life, because this is a question that I need to throw back to you. I don't have the clever technology to get you to answer the question, but which is what short-term toxicity is acceptable if you are looking at changing the probability of living years, if not decades. Because I think if it were myself, and I think what I experience is that people will potentially accept quite a high level of toxicity if that is the goal. So the issues are the uncertainties about long-term survival, which of course we don't have a lot of those data. And then the other issue about long-term survival is that people can get late effects, they may get chronic side effects, or the side effects may burn themselves out, but they get long-term sequelae, so that they may end up on lifelong medication as a result of a side effect that happened many years before. And that all has an impact on people's quality of life. So these are all the issues that I think we are still learning, well, we are going to be learning about for the next decade, because these drugs are new and we don't yet know the answers to this. Going back to the robot wars type machine, you'll be aware that they do have side effects. We'll talk about those in detail a bit more. But if you have drugs like pembrolizumab and nivolumab, there is a 15% chance of a major side effect. And by a major side effect, I mean bad enough to put you in hospital or to need high-dose steroids. It's not a completely accurate summary. We have people who we manage as outpatients, but nonetheless, it's giving you a measure of the severity of those events. In fact, according to the trial statistics, everybody gets some level of side effect, but 1 in 6 will get something bad enough to put them in hospital or need high-dose steroids. When you use ipilimumab, it's around about 1/4 of patients will get that degree of severity. When you combine the two drugs, then it goes up to more than half of people, and 55% was from the original trials. The data that was released earlier this year suggests that the figures are higher than that again. So it's a very significant proportion of people will get major side effects. And the types of side effects are very diverse. And so you can see that pretty much any organ in the body can be affected. And some of these can be difficult to detect. So the obvious ones are, if the bowel is inflamed, then it manifests as diarrhea. If the skin is inflamed, it manifests as rash. Well, we can see those or feel those, or you're ending up going to the toilet 20 times. These are fairly obvious things. But other side effects become more difficult to detect. So if the kidneys aren't working, you may be completely free of symptoms, or you may feel tired. Similarly for the liver if it's inflamed. If hormones fail, you may feel no symptoms at all. Or, as happened to a patient of mine, one of the very early patients we treated, his wife phones up and says, I think he needs to come in. I don't think he's very well. Okay, where is he? Well, he's on the golf course at the moment. And so they dismiss it. And this is a part of our learning curve. And I tell this story, and we use this as part of teaching and with the patient's permission. And in fact, when I saw him in clinic, his cortisol had plummeted dramatically. And he actually had developed very low cortisol. And the point of the story was he was on the golf course, but he could only complete half the course. And that was abnormal for him. So it's that sense of things being different for you. This is not how it is for chemotherapy when you phone up and you say, I've got a fever. All right, come in. It's not so clear-cut. So the problem with side effects is that some of them are not so obvious to the patient in terms of what you report in. And we have to be alert to those events. And so just take you through some of these short stories. And it's just really to give us a flavour of some of the events that occur. So here we have a patient who had ipilimumab back in 2013, and then in 2016 at the beginning had pembrolizumab, and really was troubled and was forced off the treatment by quite significant polyarthropathy, so sore joints and inflamed joints. And then when he came to he was then treated with prednisolone. He had another drug, sulfasalazine, and then later on, look at the difference between pembrolizumab up there, and then later on, you've got suddenly significant inflammation in the bowel. So all those months difference, and then he's treated with high-dose steroids, it gets better. Please say he continues to do very well. But the point I'm getting at is that how unpredictable is that story? Similarly here, somebody who has hepatitis, you can see, has had ipilimumab and then pembrolizumab, 2 episodes of hepatitis, quite significant on treatment, and also an inflammatory polyarthropathy. So again, you're seeing this kind of pattern of multiple events. Here's somebody who had treatment with ipilimumab and then with pembrolizumab, you see with a break in between. And in that course, he presented with lung metastases plus mets elsewhere. He developed really pronounced, intense infiltrates throughout the lung on the x-rays, and he was short of breath. And you can see we treated him with steroids for that. And the remarkable thing is, as time goes on, not only does all the infiltrate clear away, but so do the metastases. And eventually he ends up having surgery. And this is an old slide now, and time has gone on, and his remaining metastases have been removed surgically, and he continues with disease under control. But it gives a sense that here is somebody who had significant inflammation in the lungs, and it clears, and he's able to, and he still remains in remission at the moment. So if we put those kind of things together, then how do we approach all this? So for decades, we have had a way of categorizing people's side effects in oncology. And the history of that way we categorize side effects goes down to the origins of cytotoxic chemotherapy and how you dose escalate to find the right dose to put into people in the early phase trials. And this is called the common toxicity criteria. And they follow pretty much this approach. So you can see that we start off with something that's mild, that's hardly interfering in people's lives. ADL refers to activities of daily living, and there are several levels of that. So basically having a reduced ability to do stuff all the way through to having loss of independence. So that's what you can see between grade 2 and grade 3. And then grade 4 is something that's life-threatening and requires urgent intervention. And crudely, what we do is that if you've got mild side effects, we would continue treatment, and if you've got severe side effects, we'll never retreat you, we'd stop straight away. But in between, there's some variation about what we might do depending on the type of side effect. And then the other reactions that we have are supportive measures, depending on what's going on. And our treatment is really very crude indeed. It is giving people very big doses of steroids. And then at the bottom here, it says second-line immune suppression. And there's a whole raft of drugs that have come into the clinic in other diseases, things like infliximab or mycophenolate. And the origins of these drugs, some of them have been used for ulcerative colitis or Crohn's disease on the one hand, or for rheumatoid arthritis. Other drugs come from the transplantation setting. So all of these drugs are a mishmash of drugs which are poorly understood in this setting. And we are still learning how to use them best for these kind of side effects. I'll just quickly give you a sense of the range of side effects again. This is from the melanoma trials, and what you can see here is on this panel here, you have the anti-PD-1s, the combination, and the IPI, and this figure here relates to the incidence, the percentage of side effects, and the right-hand figure, the percentage of significance of major or life-threatening side effects. And all I want to do is, if you just go down that list, you can just get a sense of the kind of events people are getting. And you can see here significant abdominal symptoms at the bottom there. Going through all the way through, there's a risk of bowel perforation if colitis goes on untreated. And then liver inflammation, those things at the top, ALT and AST, those are markers we have of liver inflammation that we measure in the blood. Renal impairment, breathless, dyspnea, means shortness of breath. And you can see that these occur. Rash and various hormone failures as well, including the new development of diabetes. And you can see, broadly speaking, that the incidence of side effects are highest for the combination, next for IPI, and lowest for nivolumab and pembrolizumab alone. So what do we do? So this is our reaction. Firstly, I think that we have to set our clinics up so that we are alert to these events as they occur, rather than it coming as a surprise. So we do need to assess people when we start for fitness and comorbidities. We need to understand whether people have previously had autoimmune conditions, rheumatoid arthritis, ulcerative colitis, etc. When I started using these drugs, we wouldn't use the drugs for people who'd had those conditions. Now I think we would, but we do have to do so with some considerable caution. The way that we work is that we have structured information, so we have very, very clear medical notes so that anybody seeing that patient knows what's going on, and we have templates warning people about these kind of side effects, because we recognize this has, until relatively recently, not been widely known in the medical community. And so we need to review people on a regular basis, and you can see there's a whole bunch of blood tests that we do, and so sometimes we pick people up with side effects because they've got symptoms, and sometimes we pick it up because we're looking at blood results. So that's part of the routine. And really important here, this box here, communication is very important, not just between patient and doctor, but between doctors and doctors and nurses. That multidisciplinary communication is actually really crucial to safe practice. Clear planning, so that we have a clear pathway of what are we going to do, what are the criteria by which we're going to escalate treatment, when are we going to taper treatment down. So it shouldn't be haphazard. Review by senior review. It is really crucial. This is managed by consultants, not only by juniors working alone. That, of course, the service in the NHS is multi-level, and that's really important, and our junior doctors are very skilled in their own right, but senior review is crucial to this being successful. And thinking about alternatives, so being aware that with some of these side effects, there may be other reasons why these are occurring, not just caused by the drug, not least, unfortunately, progression of the cancer. So just being alert to how that interfaces between side effects and the cancer. Another group to interface with is the palliative care services, and sometimes there are situations where you don't know whether what you are doing is sadly moving towards a terminal care situation managed by palliative care team, or acute side effects which need to be managed very aggressively. And that's quite a difficult balance in some individuals to get right, because just being aggressive is not always the right thing if actually somebody's coming towards the end of their life. So by aggressive, I mean aggressive management. That communication is important. And then down here is the way that we've been starting to structure it. If you look at this, there are a whole bunch of algorithms how to manage these, and they typically have this traffic light system. But the traffic light system is applied to the kind of grades of side effects. Here, what we see is actually about the response. So there has to be this acute oncology service, and acute oncology, something that's developed in the last 5 years or so, has been really crucial. It means there's a defined service within all cancer hospitals, which you have 24 hours access to. And so they need to take those phone calls and understand who comes in and who does not need to come in. The assessment, if somebody comes in, is usually done by a junior doctor, so they need to have a knowledge about, again, the immediate actions they need to take, that need to take place, and then admission, and then you start getting into specialist care. These are the things that I think... I have to say, I own no copyright on these pictures. For all I know, they're copyrighted by other people. I nicked them off the internet. But that first picture is fabulous, isn't it? I assume it's slurry. But anyway, I couldn't find it. I wasn't quite sure how I'd find a tasteful picture to illustrate this, but that's the closest I could get to. So it does make the point that the obvious things are if you've got diarrhea or if you've got a rash, because they're obvious. It's this lot at the right-hand side, the non-specific symptoms, the stuff that's out of the ordinary. So somebody who's breathless, it may be that there's infiltration in the lung because of the immune response. Maybe they've got pneumonia for some other reason altogether. Maybe they've got heart failure or something else. There are other events. But maybe the nervous system has been undermined, and actually they're breathless because the nervous system is failing. They can't breathe properly. Or maybe the heart is inflamed. I can't tell that over the phone. So somebody has to come in and they have to be assessed. And it's about, again, the junior doctors at the front door understanding that it's not breathless, inflammation in the lung, give high-dose steroids. It's breathless, think hard, do a proper examination, evaluate, get senior input, think about what the right thing is to do. It's that intelligent approach to managing side effects. And so this summarizes that point. So this is the way we do it. This is kind of a template. We have a number of algorithms that are actually still in development. But it's that idea of triage, what you ask about, and then what your action is, which is who do you admit, and what the advice is if you don't admit somebody. And similarly, if they come into hospital, the red flag signs. So if you have diarrhea, the things I want to know is there incontinence? Is there urgency? Is there blood in the stool? Is there abdominal pain? So it's not just how frequent is the diarrhea, which is what gets you your scoring on the grading system. It's, are there the red flag features that make me say, uh-oh, this person needs to be seen and assessed urgently? And then what do you do on admission? And you can see that the steroids feature highly in there, but it's managing the rest of that pathway. Okay, so I'm coming towards the end of this, and I've just been given the 5-minute warning. This is where I think we're going over the next few years. What I'm highlighting is that there's real uncertainty about a lot of this. So firstly, we don't really have a good handle on the events themselves, because all of our information comes from clinical trials, and as we heard from Mark earlier on, those are not typical situations in relation to clinical practice. So we need to understand in the real world, to coin a phrase, what what happens to patients. So the first thing is simply to document properly using good, consistent tools. So the tools that I document in Birmingham are the same as those that they're using in Lancashire, which are the same as those being used in Mount Vernon, etc. So that we're all using the same tools. And so we're documenting events. So we have the relationship of treatments, we can have acute immune-related adverse events, and then the late events, and then these chronic events, and then also these long-term sequelae where the event itself is burnt out, but people might be left, for example, having chronic diarrhea because the bowel has never quite got back to normal, or they may have hormone failures which are long-lasting. So let's document that, and that's a process that has to be done prospectively and will go on for years, not just a few months. The second issue is, who is it who gets immune-related adverse events? And is it that there are particular features that make some people more susceptible than others? So some of this may be in the genes. It may be that people have particular gene variations that mean that they're more likely to get side effects than another person, or there may be variations in the non-coding parts of DNA which may make it more or less likely that they express particular genes which then affect their susceptibility to side effects. The cancer itself may have an impact. Each cancer has its own unique properties, and cancers definitely interact with the immune system. So they may have a very interesting interaction, making people more or less likely to get side effects. Environmental and lifestyle factors down at the bottom there with a cigarette. So that's really a symbol for a whole range of other possibilities. So questions in my mind is whether there's a relation to body mass index, smoking, diet, etc. So I don't know whether any of these have an impact, and they may be challenging to find out, but they're certainly plausible factors. On the right-hand side is this issue about the bacterial flora. So you have your own complement of DNA that you have inherited and which you've has evolved with you over the last 3.5 billion years, but we also carry a vast amount of DNA that is not human, and that DNA is in bacteria, viruses, fungi, and worms, and these are inside your bowel, on your skin, in other sites, and these have a very, very important interaction with the immune system and with mucosal surfaces, and so the bacterial flora may well be a very important influencer. In fact, there is evidence to suggest that it does influence whether your risk of side effects. And similarly, antibiotic use may or may not be a risk factor. And then the next point is about what triggers the events. So some of these same factors, maybe a change in the bacterial flora, antibiotic use, that kind of thing, maybe an infection can trigger an event. But also over here, I've tried to illustrate all of these are different components of the immune system. The T8 cells, which actually kill cancer cells, but also may mediate side effects. The H1 cells, which are part of that system. The H2 cells, which may actually suppress some of the immune system. The R cells, the regulatory cells, which may again be dampening down some of the side effects. The DC, which help it expose the immune system to different stimuli, and other components. So all I'm saying is that the immune system is very complex, and we don't know which of those cells are involved in the immune-related adverse events, and they may be different in different parts of the body. So that also needs to be unpicked. And then the next, so that's the mechanisms, the triggers, and the last point I want to make is down at the bottom, question 6, what is the best treatment? So we work very crudely. We use high-dose steroids, and steroids have side effects in their own right. I think, and many of my colleagues think, that we're probably overusing steroids, but we're following standard algorithms when we do so. We don't have a really good handle on how to use the other drugs, and I think part of the next decade is trying to understand better how we use drugs to suppress the immune system, hopefully in a very targeted way, so we suppress the adverse events and we allow the immune system to continue maintaining control of the cancer. So that's where I'll finish. This is the team that I work with, and I'm privileged to do so. The comment was made by Julia early on about the importance of clinical nurse specialists. You can see I was sitting at the front there, and they really are crucial to the whole team. And I'm also grateful for the support we have. We have a QE Fighting Skin Cancer is our local skin cancer charity, which is very important, supported much of my work. And KIC, which is the Cancer Immunotherapy and Immunology Centre, based at the University of Birmingham, does important work in terms of immunotherapy for cancer. And that provides a vast amount of expertise that supports our work as well. So I think at that point I'll finish and say thanks for inviting me.